Welcome everybody. Thank you for coming today to GI Grand Rounds on controversies on the long-term safety of proton pump inhibitors. Thank you to Dr. Rubin for inviting me and for helping me to choose this topic as it is timely and controversial. Thank you to my panel of experts. There's also a screen up here for you to look at, but if you guys are uncomfortable, feel free to turn around and look at the big screen. I don't want you to strain. It's a little bit smaller up there. So first on our panel, our very own Mark Chapman, an expert in gastric physiology. We also have Dr. Daniel Freeberg, who came to join us from Columbia University, who's an expert in PPI use and wrote the AGA Expert Review and Best Practice Advisory that was published this year. And Dr. Emanuela Tioli from the Department of Epidemiology. She is the Director of Translational Epidemiology, and she's here to help us interpret some of these epidemiologic studies that we've been discussing the past year. So the outline of this presentation, I'll first start talking about the efficacy of proton pump inhibitors versus H2 receptor antagonists. I will then review the indications for PPIs. We will critically evaluate the literature on PPIs and the risk of CKD. Then we'll discuss the strength of this evidence with the help of our expert panel. We'll review the relative risks of dementia, fractures, and gastric cancer, and then I will go over the AGA best practice advice. So the key points that you'll see me highlight multiple times throughout this presentation are that we want to reassure and educate our patients if PPIs are actually indicated. We want to reduce the dose to the lowest possible dose in all patients. And if there's no indication, we want to discontinue PPIs. And I think wherever we land on the literature, however you interpret the literature, these 3 points will maintain throughout. So again, I'll start with the first case here. Everyone already have their phones out. So again, in case you're just logging on for the first time, in the to box where you usually type a cell phone number, you type 22333. And then in the text message, instead of saying, hey, we're at GI conference, you type in Charles Snyder 603, and that'll log you into the poll. So the first case is a 62-year-old obese white man with symptomatic GERD and C5M2 Barrett's esophagus. He comes to you and asks if he should continue his once daily PPI. He reports that his reflux recurs if he misses a single dose of his PPI. He also has a printed email that says PPIs cause kidney disease, which is one from his golf buddies, and he really wants to talk to you about this. He's very concerned. So we have a poll everywhere here. Don't vote yet. I will activate the poll and make it full screen, and you can again read the question and then just text message A, B, or C for your answer choice, and we'll see how the room votes. Good, it's working. We got one. I'll hopefully get about 10 of these, and then we'll move on. All right, 10. 12, great. So good, exactly what I wanted was a split between A and B. So this question was written to be somewhat controversial. Hopefully you felt a little dissonance when you were trying to answer A or B. I think it really depends on where you land on your own understanding or your own interpretation of the literature. So I picked this case because Shivani Gupta just presented a Grand Rounds 2 weeks ago on Barrett's esophagus. And one of the points she presented was that there's a value in PPI. There's a shown benefit to chemoprevention, so decreasing prevention from low-grade dysplasia to high-grade dysplasia and adenocarcinoma in patients who have Barrett's esophagus. And so yes, you should continue the PPI, and really A and B is just kind of your own interpretation. So that was great, exactly what I was hoping for. Again, the key points. This one, oh, that doesn't line up, but the key point that this one hit was reassure and educate your patient if a PPI is indicated. So you can reassure this guy with Barrett's that he does need a PPI. So why not use H2 receptor antagonists? I want to briefly review the mechanism and then some of the original literature that some of the fellows we haven't looked at so much. So there are 3 major pathways of parietal cell stimulation when thinking about acid secretion. The first is the vagus nerve stimulating the parietal cell directly from the neural pathway. The second is the hormonal pathway when gastrin is secreted into the blood vessels and then really works in a hormonal pathway to impact parietal cells and secrete acid. And the third is local enterochromaffin-like cells that act in a paracrine manner to stimulate parietal cells. And this is really the one we know that impacts H2 receptor antagonists work on. They block the histamine acting on the parietal cells, whereas proton pump inhibitors are inhibited downstream by PPIs, so you bypass that upstream hormonal, neuro, and paracrine pathway, which is why theoretically PPIs are more effective than H2 blockers at decreasing acid secretion, increasing pH, and thus treatment of GERD and esophagitis. So this is some literature a lot of us probably take for granted, at least the fellows, that PPIs work better than H2 receptor antagonists. This is a meta-analysis from 1997 from Gastroenterology, where they looked at patients both with heartburn and patients with esophagitis who are treated with PPIs versus H2 receptor antagonists. And you can see that 80% of patients who were treated with a PPI were free of symptoms at 3 to 4 weeks, at 6 to 8 weeks, compared to H2 receptor antagonists who only had about a 50% at most improvement in symptoms. And as well as in esophagitis, patients who are treated with PPI have almost 100% healing at 12 weeks, compared to H2 receptor antagonists, where they only had healing at about 60% at 12 weeks. And there's other literature that supports that long-term maintenance healing of esophagitis is maintained. From these authors, they suggested that an NNT of 3, so a number needed to treat 3 patients with PPI over H2 receptor antagonists was needed to continue healing of esophagitis. And there are appropriate long-term indications. So this is from an Italian group of gastroenterologists, general practitioners, and pharmacists who put together appropriate long-term PPI indications, led by author Scarpignato last year in 2016. They, similar to what we mentioned, Barrett's esophagus, high-grade erosive esophagitis, EOE, and then some of the other indications that we usually talk about, like high-risk bleeding, patients who are on NSAIDs with a history of upper GI bleeding, or antiplatelets with a history of upper GI bleeding. They also commented on inappropriate long-term uses. I added this one here, but this is no indication. So this is patients that come to you and they have no idea why they're taking a PPI. Someone gave it to them, or it's on a hospital discharge, they continued it. So not only are there clear inappropriate indications, but no indication, I think, is a very important one that we should keep in mind. I left this for Dr. Chapman. Any comments on the mechanisms of PPI or H2 receptor antagonists that we should discuss before we do the literature?
You know, basically affect the enzyme ATP, which activates the proton. It takes a little longer to work than direct production of histamine stimulation. But when it does work, it's far more effective in terms of acid output and it probably lasts substantially longer. So there are definite advantages. In fact, sometimes I wonder why we're using H2 blockers at all. And the reason we're using them, and I think we use more now, is because of the recent literature, much of which I have problems with.
As we'll discuss
later. And people are getting frightened of PPIs. So, does anyone have the issues with the mechanism?
You showed us 2 graphs of GERD and erosive esophagitis.
Mm-hmm.
Do you have a comparable graph to show us for Barrett's? This patient is Barrett's.
You're right. I didn't put a graph in here on Barrett's.
But I mean, you have graphs that show that there's definitely an inferiority of the H2 blockers as opposed to PPIs in treating. I mean, we're not even sure whether anything helps Barrett's, but I mean,
right.
does it really make a big difference?
I think Shivani included some of this in her presentation a couple of weeks ago, where I think there are only trials looking at H2 receptor antagonists in Barrett's were added on to PPIs. So there's I don't think there's any clear data that H2 receptor blockers alone can decrease progression. We just don't have the data.
Some retrospective studies, but there are no prospective studies. There's a study going on in Europe, a randomized study with low dose versus high dose PPIs that I think is due to conclude soon. It's a big study, but progression of Barrett's isn't that common, and it may still be a negative study. So there's no high quality evidence that PPIs do prevent progression of Barrett's. Most people assume that they do.
All right. And this is what our patients are coming to us. They're concerned, obviously. We're seeing the literature, but they're seeing the headlines talking about bone breaks and kidney trouble and dementia. And it's hard for patients to interpret these risks, and that's why they're coming to us.
One other thing that I didn't mention was the hypergastronemia, which is one cause because of the rebound effect and potential possible effects of constant stimulation from bigastric levels. And there's been some intermittent work on that also in terms of reduction of malignancies, colon cancer, things like that, much of which turned out to show not much. And in fact, one strain of rats, perhaps, that may have an increased incidence of chronic neoplasms. Pardon?
What about stomach cancer?
There's no relationship between proton pump inhibitors and
And I'll show
they don't get atrophic gastritis.
I'll show some of the more recent some of the recent publications from the last 12 months. So I wanted to use PPI and CKD and risk of CKD as kind of a framework for how to think about these papers and how we evaluate them, especially because we have epidemiology representation to help us interpret. The first paper that I wanted to go over was from 2016. This gets a lot of press and a lot of discussion from our patients. PPIs and the risk of CKD. So this was out of the Department of Epidemiology at the Johns Hopkins University, led by Dr. Lazarus. And what they did was they took two separate populations. This was all data that was reviewed retrospectively, but there was a prospective cohort where the actual data was collected prospectively. This was from the ARIC study, the atherosclerosis risk in communities. They had about 10,000 patients that were followed from 1996 to 2001. They also replicated their findings in a large Geisinger Health cohort of 250,000 patients. This was all data that was collected retrospectively. The prospective cohort from this ARIC study had the benefit that they were actually looking directly at pill bottles. So patients, the first visit and at future visits, they actually were seeing what the patients were taking or hearing them read out in a list. And in terms of assessing CKD at baseline, they had lab values that proved that all their patients had normal kidney function at the start. And then they used incident CKD was determined based on ICD codes. So this might seem a little bit odd. You say, how can you really assess whether a patient has CKD based on an ICD code? There are previous studies that had validated using this that show that there's a high specificity to ICD codes at hospital discharge for CKD, upwards of 95%. But the sensitivity for picking up CKD based on an ICD code is quite low, on the order of 30 to 35%. This was timely. So at the baseline of the study, only about 3.5% of patients were on a PPI, but in the early 2000s, PPI use drastically increased, and over the course of this study, it also drastically increased. And this study showed that it didn't show, but their baseline populations had differences. So some of the main differences, and I think this is what concerns a lot of people about these retrospective observational studies, is that the PPI users were more frequently white, more frequently insured, they were fatter, they were more likely to have hypertension, they were more likely to be on antihypertensives or diuretics. And the eGFR at baseline was different among these groups. So they performed multiple different analyses. They did multivariate analyses using sex, BMI, comorbidities, medications used, and they adjusted for all those variates. And what they found was that in unadjusted and in adjusted analyses, there was an increased hazard ratio of a risk associated with patients who took PPI. They also did propensity score matching to attempt to alleviate some of these co-founders, and they found that this association held. They also used a negative control by looking at baseline H2 receptor antagonist use versus no H2 receptor antagonist use, and this did not show a statistically significant increase in CKD with patients who are just on H2 receptor antagonists. So what I was trying to show here is that they basically use multivariate analysis, they use propensity scoring models, they use multiple different techniques to create the highest level of evidence possible here. And then in the larger 250,000 replication cohort, this was all collected retrospectively, so they were looking at prescriptions from prescribers. The benefit to this cohort was they actually assessed CKD using lab values, so they trended lab values over time. Again, there were major baseline differences in this larger 250,000 patient cohort, which we'll talk about shortly. And again, with the multiple forms of analysis that they performed, they still saw a significant association with CKD.
Aspirin's the only NSAID.
There were other NSAIDs that were used. Yeah, I didn't include it from the baseline. And the negative control, again, did not show an increased association with CKD when you went with H2 receptor antagonists. They also looked at twice daily dosing versus once daily dosing and saw an increased association with CKD and twice daily dosing. And overall incident CKD was really rare. So in the prospective cohort, calculated it was 0.33% risk difference over 1 year, and in the replication cohort, 0.17% absolute risk difference over 1 year. So these are really, really small numbers at really low incidence per year per patient. And again, the H2 receptor antagonists were not associated with incident CKD. The strengths for this was a large population. It was replicated in an even larger cohort. It was long follow-up, and they used multiple sensitivity analyses. The limitations are we can't prove causality here. So we can't say that there are unmeasured co-founders, that there are definitely not other unmeasured co-founders that could be impacting the results here. I talked about the low sensitivity of the ICD codes, and we can't completely capture over-the-counter prescriptions. I just want to briefly touch on this next paper before we turn to the panel. This was from the Journal of American Society of Nephrology from 2016. This is a VA study, also from the Department of Epidemiology, where they were looking not just at incident CKD, but progression of CKD to ESRD. Also large numbers, 20,000 H2 receptor antagonists, 170,000 PPIs. Again, they had baseline differences in age, GFR, and comorbidities. But they did control for GI indications here. So as we would expect, more of the patients who had GERD, GI bleeding, ulcers, or Barrett's were on PPIs, and they were able to adjust for this. And again, they did multiple different analyses, but they had different definitions. So instead of just incident CKD, they defined this as 2 GFR readings less than 60, doubling of creatinine, drop in GFR of over 30%, ESRD. So with multiple different definitions of CKD and looking at CKD progression, they still showed that there was an associated risk of PPI usage versus H2 receptor antagonists. And they trended this over time. So they looked at patients who are on PPIs at 31 to 90 days, up to a year, over 2 years. And what they saw is that every definition here of how they defined CKD progression, over time, the risk increased over time. Although that changed at about the 2-year point where there was a drop-off. So maybe PPIs are protective after 2 years, or maybe there's a survival benefit that we can talk about. Yes, I believe so. So again, right, and then they did. Again, large-scale data, multiple definitions here, but the same limitations of a possible confounder that we don't know about. The associations were significant but very infrequent, and this is an all VA population. So they recommended judicious use of PPI, which I also recommended at the beginning of this discussion, limiting the exposure to the minimum dose necessary, which I also recommended, and they talked about close monitoring of renal function, which I'm not sure is necessary, and we'll talk about that shortly.
About the physiology of why it causes renal.
Sure. So there's many studies in the past that have looked at why CKD might be a result of PPI use. There's been studies on hypomagnesemia, which is a very rare event, but can also be linked to CKD. There's been studies on acute interstitial nephritis and a possible idiosyncratic reaction on patients. Again, very rare. So we don't have a clearly defined mechanism.
What about proton pumps?
I didn't read about that, but sure. So we have Dr. Thiele from the Department of Epidemiology, and I was wondering if she could help us piece apart kind of the strengths and limitations of this study.
So I guess there is no perfect study for epidemiologists. That's the comment of the day. But I think if you look at the 2 cohorts, which are really strong cohorts, especially the first study, it's really well designed, but you still see that there are limitations. I think the first study the limitation is in the diagnosis, which is done with the ICD codes, and as was said before, it's very specific, but it's not sensitive, so you're missing a lot of cases. The second, but the strength of the first study is that they keep asking if the patient is using the drug, so they have a good picture of what's going on chronically. Because a lot of cohort studies ask the question once at the beginning, and then they look at the follow-up. So then they assume what they see at the beginning is what happens over 20 years of time. This study actually kept asking, so they have like a good picture of what's going on. But difficulty is in the diagnosis that is not that strong. The retrospective cohort, the insurance cohort, has a very good diagnosis tool because they're measuring kidney function, so they can catch really somebody who's going down. But they don't have a good exposure measure because they are looking at the prescription within 90 days, and 90 days may not be representative of what happened in the previous 3 years. So both of them have one section that is a weakness. So it's difficult to say that they are really giving a good support to recommending change in practice. The other issue that I want to comment is that all the studies that Charlie has show clearly that people who take these drugs are different from the rest. They are heavier, they have hypertension, comorbidities, because this reflux or this gastric problem come with a lot of the other issue. So even if you adjust for confounders when you do the multivariate analysis, there's still residual confounders there that you can't adjust. And even doing the randomized clinical trial, which is what everybody thinks as the best practice and the best step, you're going to create a selection of patients because compared to groups, you need to select them. So not necessarily you will have a representativeness of the patients who take the drug. So it's a difficult topic to solve epidemiologically. But I think these data, considering also that it's a very rare, I think they had 90 or cases altogether. Last time I looked at the number of cases of chronic kidney disease was very small.
Very low.
Yeah. So it's very, even if there is an effect that 20% is on a rare disease, it's not going to show on a lot of the population you're treating.
So how do you answer the second question?
Well, the answer is that thank God I don't go any clinical work. But no, I think that what really those papers say is that you have to try as what they said before, to try to limit to as much as possible to the persons who really need it, because the thing that really was interesting there is there was a dose response. It looks like people who took it more had more risk than people who took it once. So that dose response picture for us is very telling. It's like one of the factors we consider when we look at the strength of an association. So that tells me that more than changing clinical practice is like trying to use it as limited as possible. That's my own.
So maybe you guys can address my concern. We get asked about this all the time. My concern when reading the kidney disease literature is that it doesn't seem like checking periodic kidney function testing does anything, because either you kind of fall off this cliff or not. Like just noting that the BUN and creatinine went up a little bit doesn't seem to work. So I don't know what you guys think about that.
Yeah, I was very surprised that that article, the Lazarus article, was published with an editorial encouraging periodic checking of renal function. Well, they didn't test that periodic checking of renal function produces different outcomes. That's a different question. So that conclusion has nothing to do with their results, whether you believe those results or not. I think that the gentleman asked a very good question. So Dr. Cioli hit the nail on the head. Residual confounding is the problem with all of these studies. There's always going to be some residual confounding, no matter how hard you try. What else can you do? Well, you can look for other kinds of evidence. Go away from just retrospective studies. And for example, Lauren Lane's doing that now, pooling a lot of RCTs. Mostly these are small, short-term studies, but they are randomized, so they do get rid of that element of residual confounding. Can we look? Can we see some signal of kidney damage in randomized trials? You can look at animal trials. Do we see the PPIs damage the kidneys of animals? You look for other kinds of evidence. Just like if you're looking at a criminal case, you would not just look for motive. You would look for as many forms of evidence as you could gather. So I think that's what people try to do to address this question.
I know that epidemiologically dose response helps support the association, but what about the lack of a linear time response? You get, it's worsening kidney function that first year, and then it's protective, which seems a little magical.
I think that curve that was down, it's because people get off the curves all the time. So that's kind of a healthy effect because only the resistance and the good healthy remain. So you don't see an effect anymore. I think you can look at the curve up to
2 years.
before the last,
2 years,
yeah.
One of the problems is everybody is looking at results. Nobody is looking at results. And I still want to know why. Because if you know why, then it helps us make decisions on a clinical level. I need a good answer. So maybe it's kidney, maybe it's the tubules, also the brain, by the way. You know, why? Nobody's really come up with a good answer. We can figure out why with NSAIDs, figure out why with all sorts of other drugs, antihypertensives, figure out why. Nobody's done why.
So Mark, what do you say to your patient?
Pardon?
What do you say to your patient?
I try to minimize the dose, obviously.
For Barrett's?
Well, Barrett's and such, you know, it depends on the clinical response. It depends upon the mucosal response and how you have to adjust the level of the drug. It's very difficult. We're not measuring acid secretion anymore. You know, we measure gastrin levels, so that doesn't really help in terms of quantitatively assessing how much acid is. And the fact of the matter is, we can treat acid reflux. We can't treat reflux drugs. Basically. So it's really directed at acid suppression. And, we have to base it on clinical findings. Go back to your poll. Endoscopic findings, clinical findings, so on and so forth. If people get headaches, which they do from proton pump inhibitors, if they get diarrhea, which they do from proton pump inhibitors, you really have to adjust it. Changing from one drug to another very often is not that helpful. Although sometimes it can be, but that can be placebo. Hard to say. Sorry.
Thank you.
So would you be afraid to take, from a renal standpoint, would you be afraid to take long-term PPI?
No.
Would you?
And then Dr. Freeberg, the AGA Clinical Practice Updates Committee used the grade criteria and rated the quality of these observational studies as generally very low, or some of them were low was even the best rating that the committee gave these studies. But we still seem to be making small amounts of clinical changes in terms of reducing the dose, considering cutting out for lack of indications. Any other comment?
Sure, yeah. I should say that the rating of very low is not, it's not intended to be pejorative. It's not that they're bad studies. It's just that they're retrospective studies that, like Dr. Teoli said, you know, have limitations. Actually, I think the Lazarus study is about as well done as one could do. Yeah, we couldn't do much better. I don't know. I personally, you know, these studies can be sort of irritating clinically when patients come with these questions and they want to talk about it, and maybe it's not the first thing on my agenda, but I don't think it's necessarily the worst thing, because oftentimes it is an opportunity to get people off PPIs when I sort of already wanted them to, like you said before, because the indication is not that good. And we know there's a lot of people on PPIs who have a crappy indication. So
one of the problems is walking around with hot gas. And the minute you take them off, there's a rebound effect. They get much worse, symptoms increase. So you have to figure out a way. It's like tapering a narcotic. It's very difficult. Take them off, they rebound. They're running gas 500, 600. They start pumping acid.
How do you handle that clinically?
Well, it's very good. You have to try to lower the dose slowly, and then you can, of course, use antacids. You can use, if necessary, H2 blockers, even though they do things also. They also have an effect upon liver enzymes, like cytokine, things like that.
You think PPI should be sold over the counter?
I don't think too many things should be sold over.
Well, what about PPI from there? Too late.
Too late. What are we going to do about it?
Do you have any data from EPIC of how many patients in this hospital are on PPIs? Pro forma?
No, but we could get that.
That might be a big number.
So my next question for the panel was will we see higher quality data in the future in order to link causality? And you briefly commented on this with Dr. Lane's study. Do you think that's the best possible evidence that we can expect in the future that could be created?
well, I think it's harder to get better than randomized evidence. The problem with randomized studies is that they're short-term. Yeah, they're studies designed by drug makers to show that their drugs are effective, not to look for rare side effects. So none of them have this kind of long-term follow-up. This is going to continue to be a murky area, and I can promise you, we've not seen the end of it. There'll be obesity, there'll be diabetes, there'll be more adverse effects that people haven't yet imputed to PPIs, for sure.
And there's no way to ever do a randomized clinical trial directly looking at these side effects, what I understand.
No, but what you can do is you can do some small RCTs where you take a few people, maybe healthy volunteers, and you look, like you were saying, and you try to look at some specific physiologic mechanism. We did this like for C. diff, where we just put a few people on high-dose PPIs and then compared them to themselves. So it's like an experiment but done in people instead of mice. So you can do that if you have some kind of a specific mechanism. But if you're just looking at CKD, no one would expect a few healthy volunteers to develop CKD. And the IRB would probably not be thrilled with that study design.
So there's also, you need the length of time to see your outcome, and what clinical trial will last for 10 years or 6 years, or at least, right? And so the other thing is that there is this, it's a chronic kidney disease. There are other factors, hypertension, there's diabetes that also have an effect on the kidney function. How can you take that away completely to say, well, that's the independent effect of the drug? That's even with the randomized trial, you would still include people with those comorbidities because those are the ones who take the drug, so have the indication for the drug. So it's very difficult even with the randomized clinical trial to get the right answer. Probably more about the biology and the mechanism, which is one of the pillars of the association, is the biological reason. For example, I right now would be curious to know what is the link with dementia, because I don't know enough about this, but it looks to be like so far away as an outcome. You need to have a biological reason for an association first. So,
Well, they blame a lot of things. Absorption of vitamin B12, absorption of calcium, absorption of iron, and magnesium issues, things like that. They're trying to figure out some reason why, but they really haven't. We do have people come in with low vitamin B12s within our long-term PPIs, and there's a good chance that that's the cause. We can't prove it, but it's easily fixed with the vitamin B12.
So I want to go back to the poll. So this is the second case. This is a 70-year-old woman. She has hypertension. She has CKD stage 3, symptomatic GERD with a history of LA grade C esophagitis in 2014. She's been taking omeprazole 40 milligrams twice daily. This was prescribed at the time of her endoscopy 3 years ago, and she never decreased it. She misses her afternoon doses, but never has symptoms. And she again asks if she should continue her current BID dose, but she hasn't seen the literature, so she's just asking this one specific question. Don't vote yet. Hold on 1 second. Okay, go ahead. A, B, or C. All right, and we'll view the results here. Good, so we had already discussed that advanced stage esophagitis with LA grade C or D is a good indication, an appropriate indication for long-term PPI use, but again, this hits the point that we want to reduce to the lowest possible dose. So in terms of tools out there, this is actually from Dr. Friedberg, who wrote this expert review and best practice advice. I won't go too much into it because I know you're coming back in January. Don't want to steal too much of your discussion. The one table that I really did want to highlight, at least a few of, is looking at the relative risk and the absolute excess risk of these different adverse effects. And the point that I took away from this, that hopefully you're trying to make also, is that the absolute excess risk is extremely low. So I went through this and I just highlighted this in bigger font. The risk, absolute excess risk of dementia on the order of 0.07% to 1.5% per patient per year. The risk of bone fracture, 0.1 to 0.5% per patient per year. The risk of C. diff, 0% to 0.9% per patient per year. So these are really small numbers here. And then this is one that just came out this past September that some people may have already seen in gut, which is long-term proton pump inhibitor and the risk of gastric cancer development. So one of the inherent difficulties in studying gastric cancer is that H. pylori is the biggest confounder. So this group tried to control for that by taking patients who had known H. pylori that was treated successfully and then followed them over about 9 years to see how many developed gastric cancer. And the overall gastric cancer incidence was quite low, 0.24%. But again, they found a hazard ratio of 2.44 in patients who were on PPI, which I calculated myself as 0.04% per patient per year of having gastric cancer after successful eradication of H. pylori. So this is the last case we'll go over. This is a 35-year-old woman from Hong Kong. That was a study out of Hong Kong, by the way, with a history of H. pylori gastritis who was successfully treated with quadruple therapy. Her symptoms have resolved. She asked if she could continue her PPI. And go ahead and answer this. All right, good, and we'll show, this one was obvious, discontinue PPI, that was the gimme at the end of the presentation. Discontinue PPI and confirm H. pylori presentation, eradication. And this hit the third main point that I was trying to make, that we should discontinue PPI when no indication, and also touched on the literature that we just discussed. So again, this is a tool that we can all use. Dr. Freeberg wrote this AGA clinical practice update when talking to patients. I found it's a good guide, and it's a little bit too small to read, but there's 10 best practice advice recommendations that I don't want to go over explicitly because I want to leave that for you in the future. But the main points are that it aligns with some of the indications that I talked about from the Italian group: GERD with acid complications, Barrett's esophagus, high risk for GI bleeding, and also that for other tools we go to gastro.org/GERD, where those are constantly updated for patient education and provider education. It seems like each new study is critically evaluated so that we can have talking points for our patients. Thank you very much to the panel. Anything else that you'd like to discuss? Thank you.
Great.